Hello, this is Dr. Richard Senelick. I'm a neurologist who specializes in neurorehabilitation and the editor-in-chief of Encompass Health Press. We produce a number of educational offerings that you may have listened to in the past or available online, and we hope you enjoy the one we're presenting at this moment. It's called Rehab, What is the Right Dose? A Look at the Literature. It attempts to explore the medical literature to determine, is there a correct dose of rehabilitation, how much therapy, and how does one get around determining that? This is what we do now. This is from the electronic medical record. If you're a paper and pencil person, you probably write down, evaluate, and treat PTOT speech, and don't write specifics. In an electronic medical record, here you can see someone just checked occupational therapy, evaluation, and treat, physical therapy, evaluate, and treat, and then leave it to the therapist to decide what are they going to do. But we're really not writing a prescription that might look like this, and the question is, could you really fill this out? And so this is on one of my prescription pads for Joe or Betty stroke, and it's for stroke therapy. So could you, and based on what information, what evidence-based medicine, write a prescription today for the number of sessions, number of total sessions, number of sessions in a day, the amount, what is the duration of each one of those sessions, what's the timing, what time of day, are you timing it in relationship to a medication that you've ordered, and how long are you going to continue it for? And so much of what we do today is based on our convenience, the therapist's schedule, when can they fit the patient into their schedule. We'll have 45-minute or 1-hour sessions. If it's outpatient and insurance is only paying for a certain number of visits, then the therapist may decide, well, I'm going to space it out over a longer period of time so that seemingly we're taking advantage of the fact that you're limited to 12, 18, 24 sessions, when in fact, would they be better off with a more intense therapy and doing more? And then we'll talk at the end of the lecture about how do you track and what goes on at home after the patient has left your situation. So it's time for a little bit of review. If you watched my lecture on neuroplasticity and repair, why rehabilitation works, then you, of course, remember this. I always say that when I'm presenting a lecture, if people can remember 3 things, I've done really well. If I go to a lecture or if I listen to a podcast, if I can get 3 things out of it, I think I've done well. It's hard to remember all the information from an hour-long lecture. So the 3 pearls out of neuroplasticity and neural repair is the dose matters. What is the dose of the therapy? It needs to be a functional task, not just doing range of motion exercises. And the patient needs to be motivated, or the person needs to be motivated, and it should be done in a highly motivating environment. So dose, function, motivation, if you're going to remember 3 things that are important in neuroplasticity and repair. It reminds me of the Malcolm Gladwell book. If you're a Malcolm Gladwell fan, then you've probably read Outliers. And in Outliers, he covers the 10,000 hour rule, that it takes 10,000 hours to become accomplished at something. So if I were to add up all of the hours I've spent in medical school, internship, residency, learning to be a neurologist, there's probably 10,000 hours there. If you're an accomplished musician, or accomplished nurse, therapist, how many hours did you spend becoming that accomplished person with deliberate practice, with practice of that? And Malcolm Gladwell shows that in many instances he comes up with the 10,000 hour rule. Many people think that the Beatles were an overnight sensation when indeed they practiced and they performed 6 days a week to become a very tight band and get the sound that they got. So we need deliberate practice. The 3 pearls: dose, function, motivation. Oh, I live in Texas, in San Antonio, Texas. I'm from Chicago, and lived up north for my residency and training, and then came down here. So we didn't have these kind of bushes or trees. And we're going to talk about collateral sprouting. So over here on the right side is this beautiful crepe myrtle bush. And we'd never seen these up north. They freeze up north. Well, when I was in the Air Force the first 2 years, which brought us to San Antonio, the yard, in particular the front yard, had these beautiful crepe myrtle bushes. And we were renting this home from a colonel who was overseas for for his tour, for whatever his duty was at that time, for a couple of years. And we were renting this very nice house. We were very lucky, and had these beautiful trees. Well, I came home from work one day, and they looked like what we see on the left here. And this is called crepe myrtle, and they get pruned back in the winter. And I thought, oh my goodness, we're really in trouble. When they come back, they're going to think we ruined things. And they had already hired somebody to take care of the yard because they were worried about their yard. And I thought, oh my goodness, these people have really messed up. But come spring, they sprouted new growths. Like if you prune roses, well, here you prune crepe myrtle trees, which indeed they say you're not supposed to, but they get very tall if you don't do that. And fortunately, came spring, we didn't need to sneak out in the middle of the night when we left this house, because they were these beautiful crepe myrtle trees, because they sprouted. So in a stroke or in a brain injury or in spinal cord injury, these axons that have been damaged sprout and grow, and the goal is to have them connect with the correct cells so that you get function. Here's an example of some old telephone wires. Now we have switches and everything's digital, but if I were to go in and cut all these wires, the phone stopped working. And you can see here's a conduit. This arrow here is pointing to, and all these fibers are in this. So think of this as fiber track. It could be the pyramidal track for motor function, the spinothalamic track for sensory function, and it has all of these fibers in it. And somebody comes by and gets really upset because I cut all of these wires. But look over here on the right, and I was able to connect it back together again, and everything worked fine, everybody relaxed, and there were no problems. But all I did was connect red with red, blue with blue, green with green, and everything worked fine. Well, think of the brain. We have these fiber tracks bringing all of these nerve fibers together, and now you have a stroke or a brain injury, the equivalent of getting it cut, and it ends up like this. How do we get red to hook up with red and blue with blue and green with green so that we get proper function? And what happens if green hooks up with blue and chartreuse with pink and white with black? Do we get spasticity? Do we get a movement disorder? Do we get seizures? And so the idea is there a dose of a functional task in a highly motivated environment that can direct these fibers to connect in the correct way? What we haven't quite figured out is there a neuroprotective agent that could coat this pathway and keep it from breaking down, so that when somebody has a stroke, the EMS technicians, when you call 911, could safely give some compound that would preserve these pathways and preserve axons and neurons. And we've yet to come up with a good neuroprotective agent. Still looking, but so far everything has failed. So this is collateral sprouting. And the next is neuroplasticity. How do we get one area of the brain to take over for another area that's been damaged? If the left side of the brain is damaged and the speech area is damaged, when the patient starts to speak again and through therapy, the right side of the brain may light up to show that now pathways in the right side of the brain are helping, and even in the cerebellum, a part of the brain that we typically think of as just associated with coordination and balance, takes over. So the distant other parts of the brain can take over. simple pathways, such as motor function, motor strip, that are not widely distributed and widely dispersed tend to get better quicker, whereas widely dispersed pathways or systems like attention, concentration, language take longer to recover. And this is part of the neuroplasticity, neural repair lecture, and if you want to watch that, you'll get a whole lot more information on this little bit that we've covered here. Randy Nudo did some elegant experiments back in the 90s, and he's a PhD neuroscientist who took 3 groups of monkeys and gave them all the same stroke. So they were able to go in and tie an artery and give them all a stroke involving, and for the purposes here, the left upper extremity. And what they looked at is if we give these monkeys, let's take 30 monkeys, so we'll have 10, 10, and 10. And 10 of them will give full monkey rehab, everything you can think, and we'll talk about what that involves. Another group just gets range of motion exercises and the same food and water that the first group gets. And the third just gets the food and water, same cage, but doesn't even get range of motion exercises. And they looked at how much return of function took place. And then with electrical stimulation in the brain, they looked at the area of the stroke to see had the area attached to it or contiguous to it now taken over some of the function, or was it just not doing anything? So the group of monkeys that just got food, water, same cage, nothing, they got some natural recovery. The stroke improved somewhat, but it plateaued pretty quickly. And the group that got range of motion exercises reached about the same level. There really wasn't much difference. When they looked at the brain and did electrical stimulation, they found that the area next to the stroke really hadn't taken over or helped. The neuroplasticity hadn't taken place. But what about that group of monkeys that got full monkey rehab? And this is what it looks like, and it's pretty much what we do in constraint-induced therapy with our patients with stroke. Is they had a little vest that constrained the monkey's non-paralyzed arm. And then with the paralyzed arm, they did force use therapy. And you want something that's highly motivating, involves eye-hand coordination, sensory and motor function. So they had a well filled with food pellets. And at first, the monkey had to use a forced grasp and would go in there and grasp, let's say, 4 or 5 pellets at a time. And with multiple, this is deliberate practice of a functional task in a highly motivated environment they want to eat, they were able to get better coordination, and you could decrease the size of the well that the food was in. Here's one size, and it gets smaller, smaller, so that we maybe had 3 pellets, 2 pellets, and eventually they could, between the thumb and the forefinger, grab 1 pellet. So that this is very much like constraint-induced therapy, where we start with large Nerf balls and we graduate down to jelly beans. And what they found was that that group of monkeys significantly improved in their motor function as opposed to the ones that just got range of motion exercises or nothing. But when they did electrical stimulation in the brain, over here on the right, they found that the area next to the hand movement that was for, let's say, shoulder function, now was assisting. Those neurons were helping, and there was ingrowth of axons into the area, so that we were seeing true neuroplasticity taking place as a result of multiple repetitions, dose, of a functional task in a highly motivated environment. We're going to talk more about this as we go on. It's called the Rehabilitation Internet of Things. And this is Bruce Dobkin's work. This is an article from 2017. There's also one from 2016 that we're going to talk about. And the mantra that we all have that uses the 3 areas that I spoke about, dose, function, and motivation, and this is from Dr. Dobkin's article, says repetitive practice of increasingly challenging task-related activities assisted by a therapist in an adequate dose, will lead to gains in motor skills, just what we just showed. Most restricted to what was trained via mechanisms of activity-dependent induction of molecular, cellular, synaptic, and structural plasticity with spared neural ensembles and networks. Simply, it means that if we do enough repetitive dose of a functional task, that task will improve, and what we'll see within the brain are changes in cellular, synaptic, and structural plasticity, much of what we saw in the monkey. So that's our mantra. That's what we've been preaching all along. This is from Dr. Dobkin's article. This is from a 2016 article, the one that preceded the one I just showed you. So here's a stroke, and you can see we get cell death, and this takes place within minutes to hours, and then we get inflammation and scarring, and days are going on now. And here's where we get involved. And the idea is that there is this built-in plasticity. Remember the group of monkeys that get better with natural recovery. So if we do nothing, patients will most likely get some natural recovery. But the upside, this blue arrow, is increasing disability and improvement. Now, I mean, I shouldn't say I had that wrong, increasing disability, but lessening disability and improvement in function. But the lower area, the gold arrow, shows that plasticity decreases over time. So our goal here is, can we prolong the period of plasticity, the yellow arrow, keep it up for this prolonged period of time as opposed to up here where the plasticity decreased over time, and can we decrease disability and improve function over this increased period of time by doing this? And I love this little chart. I think this is excellent in showing what we're trying to accomplish within rehabilitation. So here's an article out of Wash U in St. Louis with Catherine Lang, who's a doctor of physical therapy there, and has done a lot of really good research on dose. And the question is more better? And this was a meta-analysis looking at many studies. And then she had another study back in 2015 on the dose and timing in neurorehabilitation. Does prescribing motor therapy and the time at which you do it make a difference? So as we showed, the animal literature suggests that the higher the dose, the better the outcome. And there's been a continuous growing consensus that dose matters and that the increased dose in rehab is better. It's easier to study. It's easier to stutter too, but it's easier to study motor effects because we can measure. What does your arm do? Well, it kind of has sensory function and motor function, and we know it has a simple motor strip that controls it, and we have good, reliable data for measuring motor function. Whereas think how complex attention, concentration, language, executive functions are to measure, how distributed these networks are. So they're much more difficult to measure. So we tend to use motor function in most of these studies. So here's the question: why isn't everyone doing the same thing? You know that if you've worked at different places, the type of therapy may be different, when they administer it may be different, how long the session is. So think of penicillin in 1942. We know that it kills bugs, but we don't know, how do you give it? Is it oral? I mean, I remember getting penicillin shots as a kid. I remember the doctor coming to the house and the syringe rattling around in the kitchen as it was being sterilized, you know, in the boiling water. And then I got my penicillin shot. But do you give it by mouth? Do you give it orally? Do you give it IV? How much do you give? What's the right dose? Didn't know that with penicillin in the beginning. In the beginning, everything was sensitive to penicillin. No one had seen it, so I mean, you just gave a tiny bit and it worked. Now, most things are probably resistant to plain old penicillin. Do you give it once a day, twice a day, 3 times a day, 4 days? How long do you keep it for? I mean, how long do you give it for? 5 days, 7 days, 10 days? And most importantly, who do you give it to? So think about this for rehabilitation, the same questions, just all the same questions. How much? for how long, who do you give it, how many times a day. And this is a nice graph from Current Opinions, a neurology article, which compared dose to pharmaceutical agents. So this first column are pharmaceutical agents, so it could be penicillin, it could be phenytoin, an anticonvulsant, some of the common drugs that we use. And this is neurorehabilitation. So the active ingredients, we clearly know that. And we know, let's take phenytoin for seizures. We know that. We're going to assume that in rehab it's task-specific behavioral training that we just described. The mechanism of action. Well, you can't get a drug approved if you don't know the mechanism of action. But in this other column, do we know exactly how it works? Not really. Desired outcome, stop seizures for phenytoin. How about over here? Well, yes, we want increased, let's say, motor function we're talking about. The pathway through which the active ingredient acts to achieve the desired outcome. Well, for a drug, you have to know that, but we're not totally sure what the pathway is or how it works. The half-life, we know that for drugs. Phenytoin is long-acting. You can give it just at bedtime, and in most patients it works fine. But we don't know how long does therapy last, how many times a day should you give it, how many times a week should you give it. We know the side effects mostly of drugs. Do we really know, are there any side effects of what we do? We assume that there's no downside to what we do, but I don't think we totally know that. Same thing with toxicity and the interactions with other prescribed drugs. We mostly know that when you go to the drugstore, they give you a printout of what your medicine interacts with. But we assume that therapy doesn't interact with other things, but yet probably what we're going to be doing in the future is combining it with medications and deciding, does that help? Does it make it worse? So that's an area that we need to explore. So the basic questions: when do you provide therapy? In the acute phase versus the subacute phase, when we mainly are seeing the patients now after they've been in the acute care hospital. There's a whole argument about how early can you start therapy, although most people believe it's not a problem starting it early, and starting early in the ICU has shown to be very beneficial. And then chronic, what do we do about patients that reach plateaus and stop getting better? Then they seem to improve if you do therapy again. How much therapy? Do you do it twice a day in an acute setting, or a subacute setting, such as an inpatient rehab hospital, in an outpatient setting? We just arbitrarily pick twice a week, 3 times a week. Sometimes people say, well, I live out of town, I'm only going to come once a week. How many total sessions? Frequently determined by the insurance carrier. What should the activities include? We already said that they ought to be functional tasks, but specifically what should they be? And then this last one I just love, and this comes from the article, What is the Perfect Dose? Do you couple this with plasticity enablers? I love that term. So should that be pharmacologic agents? There's been a lot of studies on the use of amphetamines or stimulants, the use of SSRIs like Prozac. You're going to see a lot come out. Today is, what are we, at the end of April 2018, just so you know when this lecture was put together. You're going to see a lot more about transcranial magnetic stimulation and direct current stimulation and combining that with therapy. And people are getting really terrific results. So how do we measure dose? We tend to measure it in therapy, we measure it in minutes. But the time scheduled in therapy doesn't really equal the actual time attending to therapy, because what happens? You've got to go get the patient, bring them to therapy, then they're set up, they may get tired in between. So do you really get maybe 20 or 30 minutes out of a 45-minute or hour-long therapy session? Do you really know the number of true repetitions that take place? And task specificity varies, and it's got a challenge with increasingly difficult tasks. So I take guitar lessons, and if I want to get better, I have to work on those things that I'm having difficulty with, that are much more difficult. If I just continually work on the things I've mastered, then I don't get better. so that we need to titrate this, and this is what they've done in the animal studies, such as the one I showed you, where the well gets smaller and it becomes more difficult for the monkey to get the pellets out. So repetitions of just overlearned activities don't lead to new skill acquisition. Constraint-induced therapy, when this first came out, they were doing 6 hours a day for 10 days. And they had graduate assistants and volunteers helping provide this degree of therapy and repetitions, whether it was cutting vegetables, manipulating coins, putting beads or beans in a jar. And then somebody said, well, let's try it 1 hour a day, 3 days a week for 10 weeks, and the outcomes were the same. So the question is, how much do we do? This is from Dr. Lang's work, and just to show you there is a dose relationship that came out in these meta-analysis, that the more dose seemed to get better outcomes. There's a whole lot of stuff mixed in here on the left side, but there seemed to be a tendency toward this dose relationship. But in her key points, where the arrow is here, optimal dosing will not likely be a single value for everyone, but will vary based on clinical presentation of each individual. So that it's not so simple to just say, well, I need to provide more dose, so instead of 2 hours, I need 3 hours. I need it really 3 days a week, and it's going to vary from patient to patient, and our challenge is figuring that out. We all live and die by the 3-hour rule for inpatient rule. This Medicare decided that in 1982, so that's how long this has been around, that 3 hours of therapy is the right amount of therapy. At the time this was decided, was there any science behind this? Not really. And then the rule was changed, I forget how many years ago, but much more recently, to you can spread it these 3 hours a day times 5 days a week over 7 days if you have a medical reason for doing it and you document it. But what we're really looking for is science that supports how much is the right dose of therapy. This came from the Journal of PM&R in 2013, which actually did show that less than 3 hours a day, the outcomes were not as good. Now, getting the upper end was a challenge, and in the study, it showed that going higher than that was questionable as to whether you got increased benefit over 3.5 hours, but it didn't look at, again, all those things we're talking about, the timing of it, how did you split it up, when did you give it. But we do know that less than 3 hours a day of therapy, the outcomes are not as optimal. This was a very big study. It was published in 2016. This was the eye care study. It was a long-awaited study called The Effect of a Task-Oriented Rehabilitation. Let me start over on that. The Effect of a Task-Oriented Rehabilitation Program on Upper Extremity Recovery Following Motor Stroke. So let's kind of walk through that. What did they compare? They looked at what they called intense, high-repetition, task-oriented therapy. But those were just 31-hour sessions 3 times a week for 10 weeks. And one can seriously question whether, is that really high dose? Now, was high dose compared to their other therapies, but it could be that patients were, even in this high dose, underdosed. They recommended constraint-induced therapy, but it wasn't mandatory, and we'll talk about that in just a little bit. They had usual and customary care, and they didn't dictate how much that was going to be, and then left it up to the therapist to do no specific dose. And they compared baseline, 6 and 12 months. Mean days in stroke was about 46 days. And the patients all had moderate arm impairment without sensory or cognitive impairment. So this is a really specific group of patients. It did not look at the wide group of patients that we all see. 361 patients, and they spent $12 million over 7 years. Huge study. So once you're into this study, even if you see flaws in how the patients were categorized how much therapy they're getting. You're spending so much money and you've had so much time invested in it. The accelerated group averaged twice as much physical therapy as the others, and they did better at 4 months, but over the 1 year, there really wasn't a significant difference. But the problem is you cannot generalize these results to other outcomes, because we all know that stroke patients, it's more than just motor function. There are all kinds of quality of life outcomes, other impairments such as walking. And so this looked at just a really small area of stroke outcome. And the differences in dose of rehabilitation in the eye care study may have been insufficient because it may be that the patients were getting constraint-induced therapy because the therapists who were doing their usual therapy were doing the latest and most modern and recommended types of therapy. And it may have been that more therapy over a shorter period of time may have been effective. As we said, there may not have been that much difference because these were academic centers, and usual therapy may have been the highest level of therapy anyway. So let's look at another study. This is from the Annals of Neurology, and I showed you a little table or quote that came from this, and it's called "What's the Perfect Dose for Practice to Make Perfect?" And this looked at dose response in people who were at least 6 months post-stroke. And this was a lot of therapy. So to determine the range of dose of task-specific upper extremity limb training that produces the greatest improvement in outcomes in people greater than 6 months post-stroke. And they had 4 doses of therapy. Looking at the number of repetitions, this is of upper extremity tasks. So the lowest dose was 100 per session for a total of 3,200 reps, then 200, then 300. And then individualized, these were folks that could, whatever they could tolerate, they did. And so they got a big dose of therapy. It was 1 hour a day, 4 days a week for 8 weeks. So we would say, well, that's a lot of therapy. And some of the patients in the individualized had up to 100,000 reps. So we're getting Malcolm Gladwell territory here. And the hypothesis was that the people who received the higher dose would have better outcomes compared to those with a lower dose. Well, it's interesting. The patients felt they improved despite there was small objective motor improvement. 90% felt they had meaningful change attributed to therapy, despite the fact that maybe there wasn't a change in what was being measured. So what this tells us is that there's other factors that are going on, just like in the eye care study that didn't look at quality of life and walking and other measures to say, well, did the dose really make a difference? The dose alone may not be what we need to look at. It's what we're going to combine it with. These results were very much unexpected. It was thought that the big dose would clearly make a big outcome. So it's unlikely that task-specific therapy alone, no matter how high the dose, is ever going to exceed the magnitude of the effect observed, which means we may need to combine other interventions. And we talked about that earlier, that it's, and Catherine Lang came up with that each dose is going to need to be individualized for the patient, and it's going to be a combination of dose and pharmacologic agents, transcranial magnetic stimulation, direct current stimulation, multisensory feedback, and the prescriptions that you're going to write in the future are going to be much more complicated and should be much more specific than just saying evaluate and treat. And if we still end up doing that, then it's going to be up to the therapist to say, well, okay, well, now wait a minute, what do we need to do? Maybe I need to go back to the physician and say, have you thought about putting, remember the term, a plasticity enabler, and prescribing that for the patient and combining it? And I think we're going to just see a whole lot more come out in the literature in the next couple of years. So, but wait a minute, we had this study that just said, well, we didn't see much difference. And here's another study from 2016. And what they asked is, does adding high-dose conventional therapy to robotic-assisted therapy in chronic stroke patients make a difference? So here's doing exactly what we just recommended in the prior slide. These are chronic patients. They're at least 6 months out. They took 127 patients, a mean of 4.2 years out. So it was from a half a year to up to almost 20 years out, and combined robotic therapy with the normal intensive therapy. And then they compared it. And there was a significant benefit of intense therapy, combining robotics over usual care at 12 weeks. But then again, it seemed to attenuate over time. And we're going to talk about this at the end, is how do we influence what goes on at home? How do we influence what goes on over the long term so that we maybe can better embed these results and patients have more lasting improvement? We all know that patients are in a rehabilitation hospital and they have this intense experience and then may regress when they go home or leave our setting because they're not getting that same intensity of therapy. And we'll just wait another minute. Here was another study from 2016, and it's called Short Duration and Intensive Training Improves Long-Term Reaching Performance in Individuals with Chronic Strokes. So they're saying that, wait a minute, we think in chronic stroke patients we can make a difference. This was 78 stroke survivors, and they were able to improve what they measured in the laboratory, but they were not able to translate that into function at home. And again, that's our challenge, is what goes on at home when the patient leaves our clinic. And they questioned whether the patient's rapidly motivated, what happened when they went home, was overall health an issue. So we've got to become more creative in what we do with patients. It's just not good enough to write the prescription, have the therapy, send them home. And then in stroke patients, we go ahead and follow their hemoglobin A1C and their statins and their blood pressure and say, well, we did the best we could. So let's assume that if more is better, then do we need to increase therapy time both within and outside formal sessions? How do we enhance the environment? Remember the third one of my, I think we had dose, we had function, and we added motivation. So ideally, we're going to use active time in a movement practice or movement repetitions, and longer length of stay in outpatient therapy would be really nice. We know that particularly in elderly patients, we get a little extra time in a stroke patient, but the literature tells us that if we can keep these patients longer, we're much more likely to get them home and get more of them home than just maybe the extra day and a half or 2 days that we're given if they're just because of age put in a different group. So how do we get more dose? One aspect we talked about, remember, is the environment. And this is out of Nature in 1997. And here's a wonderful enriched environment for mice. They have all these toys to play with. If you had gerbils or hamsters at home, you probably had this, and they had their little cage and wheels. This is more likely the way mice are in an experimental environment. If you had a job to go in and clean the cages and feed the mice while you were in graduate school or medical school or college, this is what you did. And on the left is this cage or glass container that had mice, and it had the name of the experiment on it. And what this experiment looked at was neurons. So mice and animals that are further down the evolutionary scale have more stem cells. So they looked at the number of neurons, and this is in the hippocampus, and they looked at the mice raised in that enriched environment on the prior slide with all the toys versus the control mice. And the ones raised in an enriched environment had many more neurons. And this is, well, how many years ago was this study? 20 years ago. And there's just been a whole group of articles that keeps coming out. This one in the lower right-hand corner is from 2017. Oops, I hit that too soon. Showing an enriched environment improves function. And we know that patients being treated in an enriched environment have better outcomes. So one of the things we want to look at is enriching the environment in which care takes place. This is an interesting article looking at how do we do that, and it came out in 2015 in the Journal of Rehabilitation Medicine. It says an enriched environmental program during inpatient neurorehab. So how do we get more hours of therapy? We only have so many therapists, and there's only so much we can do. If anything, we have less time, it seems, to treat than we used to. And so they looked at an activity arcade. And they took 103 patients and randomized them. This is over 14-day length of stay. They were all neurologic patients. And they created an activity arcade. It was 2 hours a day, 5 days a week. It didn't require a licensed therapist, but an allied health assistant, not a therapist. And what they looked at, if we look at this list on the right, a lot of activities, daily living, but functional tasks, had a library with reading materials, a music station, visual perceptual tasks, shopping corner, which is a lot of making lists and sequencing and organizational skills, electronic funds transfer, automatic bank tellers, board games. Think about all those games that we played as kids. They're all educational games. And they got their 2 hours extra of this a day. And this group of patients, the ones that did this, had significant improvement in cognition, attention, perception, physical function, and with a key overall quality of life, not to mention socialization. So we enrich the environment and improve the outcome in a relatively easy way to do this. And so it's something you really should think about. Pull this article, Journal of Rehabilitation Medicine, and you might want to take it to your administrator and see if you can organize this in your facility. Well, here are the two articles from Bruce Dobkin looking at the future. And one was the specific requirements of neural repair trials for stroke, and that's where that graph came from that I showed you. If we can prolong neuroplasticity, we'll improve outcomes. And the next is Dr. Dobkin looking at, well, how can we monitor patients at home, and what type of devices could we use to monitor them at home? So here's that graph again, just as a review. We had our stroke up front, cell death, scarring. Here's plasticity decreasing over time. And here's improving function, and it tends to plateau. And plasticity tends to decrease. And so the question is, what can we do to prolong plasticity and increase function, decrease disability? So if we're going to look at what can we do with the patient at home or in outpatient therapy and between sessions, this is the key, or even in the hospital, what can you do between therapy sessions? We're going to work on strengthening, fitness. We talked about specific skills, enriching the environment. Lots of new experimental devices are coming along. Transcranial magnetic stimulation is approved for depression already, and I don't think it's that long before we're going to see it approved for rehabilitation. The whole idea of combining this with pharmacologic agents. Many of us use the drugs off-label with patients. And there is a whole literature, and it's a whole nother lecture. And then our stem cell implants are going to make a difference. I think we're going to see this. So let's talk about a directed home-based therapy program. We're going to do this at home. We're going to have family support. We're going to have to figure out how to do it at home without a visiting therapist, because we've now run out of approved visits. And insurance, whether it's Medicare or private insurance, is only going to pay for so many visits. And what Dr. Dobkin's looking at, as are others, including ourselves with Encompass Home Health, how can we monitor this at home without someone actually visiting the home? And how do we provide supervision from a distance, telerehabilitation, and provide feedback? And how do we maintain routine contact with the participants? So as we spoke earlier, we really have no idea what a patient does as far as conditioning and physical activity between sessions or after formal therapy stops, because self-reporting is highly inaccurate. If my guitar teacher, I take a guitar lesson every Monday night, and he doesn't ask me this, fortunately. It says, well, how much practice did you get in this week, Richard? I don't know. Well, one, could I accurately report that? Probably not. And then if I didn't practice at all, would I be honest and say, well, I'm really sorry. I just didn't have time. I was too busy recording educational lectures. But we're very bad at self-reporting what we did or how much therapy, or it doesn't matter what activity. How much did you work out? How many times did you go to the gym? How about your diet? Are you hanging in there with your diet, and how compliant were you with that diet? So we need a way to monitor patients and get feedback so we have an accurate way of knowing what's going on in between therapy sessions. And this is where this whole concept of mHealth is just fabulous, and is exploding and is going to explode within rehabilitation. And mHealth is the use of mobile phones and other wireless technology in medical care. So we all use our smartphones for a million things. I mean, constantly, all day long, I'm Googling things. I mean, for a physician, healthcare professional, doses of medicine, looking up diseases that you just forgot about or you're not sure about. The information is all there. But this is kind of the use of mobile phones to monitor health situations. So the Internet of Things is a network of physical devices and other items embedded with electronics, sensors, software, and connectivity. In other words, it's really about connecting anything with an on-off switch through the internet. I mean, our refrigerators are connected, your televisions, think about all the things you Bluetooth that are connected. And we're going to show you in just a bit all the things that a patient is connected with. So here is the medical Internet of Things. And interesting enough, this article by Dimitrov is from Bulgaria in 2016 in healthcare informatics. So here's the physician, and we've got our tablet or electronic medical record over here and in the cloud. And so here we're interacting with the patient, kind of. And here's the patient who in many acute care hospitals have access to their medical record. Many doctors' offices have patient portals so the patient can access the physician, and we're now in the cloud. And so we've got this part pretty well connected and coming along nicely. But here's what we need to get a little bit further. We need to have wearables on the patient transmitting information to us that they can access and we can access. So here's our patient at home, and here's rehab tracking. You can do medication tracking, vital signs, biosamples, and I'll talk more about what they're doing at the Ability Lab as we close. But now we're going to put these wearables on our patient, and you can see here's all of these functions that now are going to interact with us, and here's our health coach or person I'm going to talk about in just a minute who can monitor many patients and know what they're doing at home and supervise that time in between their sessions. What makes this possible? Look at the growth of smartphones. I mean, the computing ability of your smartphone so far exceeds the computers that took man to the moon. It's just amazing. So that left side is in 2010, 27% people had smartphones, and in 2020, it's going to be 92%. So we're going to monitor home strategies. We're going to have wearable, wireless, inertial, physiologic, and biologic sensors. We're going to have the patient wearing sensors that can then transmit that information to us. Think about Fitbits now. I mean, how many people listening have Fitbit, track their steps with their phone, tracking exercise? There are devices you've seen advertised on television all the time where people can monitor their heart rhythm and check whether they're in atrial fibrillation and transmit it, virtually instantly to a physician, and it also gives them a feedback to know whether they're in atrial fibrillation. So you need a modest telerehabilitation program. You need a centrally located therapist, aide, or nurse practitioner who can periodically monitor the activity via a smartphone or tablet. And that person, if they give feedback and call that woman we just saw sitting at home and takes 15 minutes for one person, that one individual should be able to monitor up to 100 people, according to Dr. Dobkin. And this is from Dr. Dobkin's article. This is some of the things he's doing in research now. I'm going to show you different type that the Ability Lab at what used to be Rehabilitation Institute of Chicago is doing. And the problem is the commercial sensors, the Fitbit, your phone, and the algorithms that they use, they're for healthy people and people that walk at a community ambulator rate and not a geriatric rate. And we all know this from rehabilitation, that there's a geriatric rate, which I think, I don't have that in front of me, is 0.8 meters per second, and I could be off by a bit. And then there's to maintain as a community ambulator, you need to be 0.6, I think, meters per second. And if you fall below these rates, your fall incidence increases significantly. And the sensors that we have out there right now for people are not built with algorithms that are for our people with disabilities. So what Dr. Dobkin is doing in his lab is coming up with accelerometers, ergonometers that you can wear on your wrists and on your legs. Here's your smartphone. This is a stretch band for strength or to monitor resistance, and has a number of devices that he's working with in his laboratory. Let me go back one slide, just talk about that a minute, how that would work then. So what we're looking at is a way in which you can gather this data on the smartphone. The smartphone then can be put on a charging device, and while it's on there, and the same thing with the devices, and particularly the one I'm about to show you, this wearable patch, can be charged at night, and while it's transmitting the data through Bluetooth over the internet to whoever is monitoring it, so that the patient doesn't need to do anything but wear the device. The Rehab Institute of Chicago is now called the Ability Lab, and earlier this year, February of 2018, had a press release and has developed wearable patches. And with a wearable patch that is programmable, it's waterproof, comes off and can be placed on a device that charges it overnight and is capable of transmitting the data. They can program this to monitor a whole host of things. So this one up above monitors sweat, which you could correlate with activity. When I spoke with Dr. Rogers in their lab, he said that the folks who make Gatorade are looking at that so that people can monitor how much they need to drink based on their sweat. This is for swallowing on this gentleman's neck, and they can also monitor speech and separate speech from swallowing. How often did the patient speak? And actually come up with a loneliness measure. Is the patient having any interaction? They can have a wearable patch that is placed in the center here that can measure motor function, activity, steps, and a whole host of activities with simple, not so simple, but a wearable patch which is waterproof and chargeable. Here are ones that can be put on the extremities. So we're really excited about this. This is from their press release of the type of things that they can measure. Just think about, I have a friend who's diabetic who, with a device that is on over his shoulder, over the deltoid region, measures and transmits his blood glucose. We know we can do that with heart rates. We have devices, a Zeo patch. A patient wears it for a couple of weeks and they mail it in now, and it records all of their heartbeats, and rather than those old big Holter monitor devices that people had to walk around with. So what we're going to see is these devices, the wearable patches that are going to now allow us to monitor the patient's activity. With this telerehabilitation program, we should now have somebody that can call up and say, you're just sitting, you're really not active in between sessions, and monitor their progress. So this is all very exciting stuff. You're going to see this rehabilitation of the Internet of Things combining with mHealth and telehealth. Now, the argument you might say right now is, well, wait a minute, nobody's paying for this. We can't do this because there's no reimbursement for this. but it's going to make enormous sense. And I am optimistic that this is the future, and this is where we will see reimbursement. There's a whole generation of physicians from the baby boomer generation that are retiring. We're going to have this physician shortage. We're going to see more mid-level health practitioners involved and these type of activities. So the future is exciting. I hope you're ready for it because I am. And with that, I want to thank you for joining us for this educational program. We have others you can go online and find. If you're a physician, you can get CME credit through WashU, and you can contact us, and here's the connect information, if you have any questions about this program or about other programs or have suggestions for future programs. So I want to thank you for joining us, and I hope you'll join us again.